Okay, so that's how we define quality. Now, stage 2, assessing quality. We then need to select the appropriate method. And as we remember, of the 4 different dimensions of quality, there are different ways of looking at, you can choose to look at different aspects, different dimensions of quality, but there are different methods we need. And quantitative health surveys alone only really gives us the service of the data. And for us just to be mindful of that, for some, we really like humanity, a survey would only give you scraping the surface, a reductionist approach. But what we really want to go more in depth, we probably do need some qualitative surveys, so such as focus groups. So for safety, we can use case record review to look at how quality is. Adverse event reporting, many clinicians are used to doing that, so nurses have to report an adverse incident. Doctors too, if there was a near miss, if you've got a surgery in the wrong leg, now actually that was reported, yes, yeah, like right kidney, left kidney. So now, we realize we can't do that. The doctor now needs to go and mark the kidney, put a big permanent marker on the leg that needs to be operated on, and don't open the good leg and leave the fracture. Critical incident inquiry, that's qualitative, a deep dive into what went wrong. When there's really poor quality care, usually when there's we call them MMM meetings, there's not chocolate in England, morbidity and mortality meetings, where you review cases who have were complicated and who've led to mortality. Usually there's a review, and then there are also various forms that you might think about your own examples from in your country. Effectiveness, we have clinical databases in the form of clinical audits or cohort studies from areas. And also equity, if you want to look at fairness, we can get it from routine data and government records. Okay, so let's have a look at how England looks at safety, the aspect of safety. There's lots of official statistics. Safety is a really important core dimension. So since a long time, there's a huge, many high-income countries do this, but in England, there's a long tradition of capturing a lot of safety data. And a lot of it is routinely collected now. So there's official statistics. We've got a standardized hospital mortality index, so by NHS Digital, National Health Service. And then we've also got some commercial statistics as well that private companies have started and are widely used. Then we also have avoidable deaths, which NHS England uses. Hospital-acquired infection, this was a huge headline-making newspaper making lots of news a few years ago when we had lots of MRSA bacteremia in hospitals. And so there's been a huge effort to prevent it, but C. diff is also problematic. So Public Health England does routine measures of any critical health care-acquired infections. And also emergency readmissions. So within a certain number of days is considered unsafe if they've been discharged and had to be readmitted to hospital for the same reason, for example. And NHS Digital also measures that. We have complications studies, patient safety incidents, which I mentioned already. Then we're also collecting patients' views on safety, but that's moves on to humanity as well, and staff views on safety, etc., etc. Assessing effectiveness, and I think personally I'm most interested in this because my research is also how do we look at effectiveness. But it's also one of the most challenging. How do we measure it? And one of the ways, which this course also uses, is a nice framework to do, is we can measure in 3 ways. First of all, inputs, structures. It's nice and easy and cheap. A lot of lower middle income countries use this structure to measure effectiveness. Essentially is the service available? What are the inputs of the service? How many doctors are there? How many nurses are there? Have you got the facilities? Is there how many health centers is in the village or some, for example? The next easiest is processes. We can measure how much activity we're doing. We are making the assumption that the more we do, and that the activity we're doing is good for the patient. So are people getting the treatment? Are people getting the drug? How many people are getting treatment? How long the waiting time is? So these are process measures. It's easier and cheaper to measure than outcomes. And we will assume that there is a positive linear correlation, positive relationship with outcome. Okay, and then essentially complex and expensive. And my second talk will be on patient-reported outcomes as well. So I'll go into more introduction on that. But essentially, outcomes is what we're interested in for effectiveness. We want to know if the patient is better. Are they surviving more, for example? Is the quality of life better? Is their health status better? And which outcomes are better? Is treatment A better than treatment B? Is hospital A better than hospital B? Essentially, that's what we're about. So what is the result? Is outcomes. So let's look at some examples of how a study, this is WHO World Health Surveys on how, on effectiveness. So they have used inputs in understand how safe the service is. They're measuring quality of a facility in 18 African countries. So the bottom line, facility has water on the site nearby. Facility has no visible waste. Delivery room has soap and running water. Delivery room has a box for sharps disposable. So essentially, this is inputs. Is this facility available? Is this facility not available? Is there a soap and running water for maternal services, essentially, etc., etc. So structure, nice and easy to measure. You just need to go in and, oh yeah, so tick, okay, yeah, water, yeah, okay, yeah, sharps box, yeah, done, okay, has water, okay. So it's easy and straightforward to do. This is an example of using processes to look at effectiveness. So basically, they're looking at, has the, for maternal services in this case, women been offered a service where women between 18 and 69 given a pelvic exam? Did the provider tell the women to come back if they were bleeding after the delivery? Did the provider tell the caregiver if the child has illness, what the danger signs are? The provider took the child's temperature with a thermometer. So again, we're measuring, has this been offered, has this been done? So this is an example of measuring effectiveness in the dimension of quality, a process measure. Okay, so when you next look at someone assessing quality, whatever data you're given or survey results, you can think about, oh, what dimension of quality are they looking at? Is it safety? Is it effectiveness? What level of the model are they using? Are they using inputs? Are they using processes? Are they using outcomes? So that's quite nice to frame our thoughts when we next look at research data. So in England, it's been popular to use to look at effectiveness with a measure of combination of quality and outcomes with national clinical audits. And you can see that lots of high-income countries are similar to the NHS, very interested in measuring. We're in an era of accountability and assessment. So we like to measure, we try to measure how effective our services is. We've got lots and lots of clinical audits. A lot of it is funded by NHS England, and it's called the Audits and Patient Outcome Program. Majority of it measures processes and also mortality, because patient-reported outcomes are much harder to capture. But you can just see that there are lots. 33 nationally funded and 20 other funding sources. So 50 different national clinical audits, and this is across the entire country. You might think about in your own country whether you are familiar there are national clinical audits and whether or not there are just as many or even more, or maybe they're in development, that they're becoming more common. In the sense that a lot of governments are trying to assess what are we doing to our patients and is care effective. Okay, so how do we compare? Okay, it's good enough measuring it and assessing it. How do we compare? And Jia Sensei asked this question, really good question after our introduction. And yes, how do we compare? And it's very challenging indeed. So why is it challenging? Essentially, there are three reasons why it's challenging. Data completeness, How much missing data is there? Just probably missing data. Who is missing? What's missing? Why is it missing, essentially? So we always have to remember the framework I gave you when we look at data, think of the reasons why. Statistical factors, demand factors, and supply factors as well. So look at the data completeness. Do we think it's a complete picture? Secondly, data validity. Are we using the same definitions, diagnosis? Are we comparing apples and pears, or are we comparing the same thing? Sometimes the thresholds are different as well. So the best care for what we provide for, we say, good is in one country or in one region, there might be a different definition for what good care looks like. So just to be mindful of those, is the data valid? Are we using the same comparators? Data reliability. Are the observations reliable? And really this is saying, are they recorded in a systematically different way? Is there any systematic bias? Is there any intentional gaming? If we know that there are hospitals that wanting to compare with each other and they're providing for audit, are they observing and collecting information in a consistent manner, basically? And finally, this is most important, it's case mix adjustments. To make a meaningful comparison, we need to ask the question, are we comparing similar patients and cases? Is it a fair comparison? So sometimes, we think the comparisons might be confounded, and there might be legitimate confounding factors. If people are more severe cases in one region of hospital, people are older, for example. So that's a relatively easy to adjust confounder. But what about severity, comorbidity? So lots of places try to do some case mix adjustments, and which is basically using statistics and clinical characteristics to risk adjust for the differences that we see. But mindful that we can only do that for confounders we know about. If we don't know, there are unknown confounders. There's only so much we can do. Measuring severity, for example, is rather difficult. And also comorbidity is patchy. Sometimes it's very well recorded. Sometimes it's from routine records where people try to pick disease diagnosis, which is difficult. Sometimes it's self-reported, and you can see the challenges there. Okay. Assessing quality, let's look at humanity, patient experience. For humanity, patient surveys is very common and popular in England. The NHS inpatient survey and the GPPS, which GP patient survey, both are quite large. The GP patient survey is everyone who's registered to a GP, randomly selective sample is sent out every year, like to 1 point something million people, and everyone gets posted a survey, and people can return it. At one point, there's something called friends and family tests. A simple questionnaire after you've had a treatment in hospital to ask you if you would recommend this hospital or this care to your friends and family as a kind of star rating. So people want to try to do that. I mean, lots of different ways of trying to assess patients' experience with varying different methods, varying success rates, holistically, like the friends and family test, which is an overview, like when you go to a hotel, you score it out of 10 or something. And then to the very more detailed ones, like the patient survey, to ask you exactly how your contact with your general practitioner was, how long your consultation was, much more detailed, in-depth questions as well. So a variety of them. And we know there's also complaints procedures, and to try to understand patient experience overall. And there are much more qualitative ones, like local in the trust, and also locally collected in the trust, and also nationally as well in England. So you can probably think about in Japan or your own country, what it's like. Okay, so this is from the same data, from the WHO data. They tried to also look at humanity patient experience in the maternity services, so lower middle income countries. So this is an example of what they asked in the survey. Was the caregiver able to choose the child's provider, for example? So these are examples of questions you would ask to assess dignity, respect the patient received, the humanity aspects of it. Provider was told to caregiver the child's diagnosis, and the facility has a system to obtain patients' opinions. The provider asked if the patient had any questions. So again, looking at processes and how the patient may have experienced them. Finally, it's important for us to consider the level of comparison. Okay, so we can look at it on a macro level. The WHO does that, the Commonwealth Health Fund does that, lots of other levels, such as the OECD countries, compare different things. So this is the macro level across internationally, across systems. Sometimes nationally as well. So maybe your country may have a national report. National clinical audits in England does it at a system level for nationals. And then we've got a meso level where we're looking at the institution. For example, you have hospital standardized mortality ratio and you compare the differences between different hospitals or in your own hospital. That's in the meso level of an organization. And then we have micro level when we're going a little bit deep into looking at within the different aspects of service within an organization. Guidelines, survival rates in a diabetic pathway, for example, cancer pathway, lots of those. So just to think about what is the level of comparison, being mindful that you've consciously chosen or consciously looking at that level. Okay.